Dr. Leasley, how are you?
I'm doing very well. I'm ready to go if y'all are ready.
Welcome. Yes, please.
All right. So this was just a case that Dr. Petrov and I did recently. It was a robotic resection of a mediastinal tumor that was involving a bilobectomy, a phrenic nerve resection, and a diaphragm plication. So this was a 27-year-old male. In December of 2022, he'd presented to the emergency room with a 4 to 5 month history of chest pain, shortness of breath, increasing fatigue. He underwent a CT scan and subsequent biopsy, which showed a non-seminomatous germ cell tumor with predominant embryonal features. And for that, he underwent induction chemotherapy. So I'm going to show his pre-induction CT scan first. And just some things you can see here. There was not direct extension into the SVC, but he had a lot of compression. He ended up developing a thrombus there requiring anticoagulation. And then this was our post-induction scan.
How was the biopsy achieved, Dr. Leasley?
IR.
Okay.
But he had a fairly good response here. I'll go a little slower. You can see that the SVC is now open. There's much less compression. There still is compression on the right atrium, but a pretty good response.
Yes.
So this is how we position the patient for surgery. So one of the things that we had considered was, given the invasion or compression previously of the SVC and the compression that we could still see on the right atrium, we weren't confident that there wasn't direct extension. So we positioned him in a semilateral position. We did have groin access, as you can see. We have the pump in the room, and we had cardiac surgery on standby in the event that we did need to go on pump. This is what it looked like when we first entered the chest. You can see there's clearly tumor all up, extending here in the mediastinum. We started with a plane that we could see, so we started here on the pericardium. You can see the phrenic nerve in that last video. This is heart below, tumor above, left chest on this side, right chest. We did end up getting in the left pleural space. Here we're dissecting off the innominate vein. We traced that back to the SVC. It was much more fibrotic at the SVC. This dissection was quite a bit more difficult. So here's SVC, innominate. But eventually we were able to get a good plane there. So we were actually able to fully get around the SVC. We sent margins from all of these areas just to make sure that we were getting an adequate oncologic resection. We flipped the tumor down now, so we're approaching taking it off from the SVC from above. Once we'd completed that, we flipped it off the heart. And so now we've rotated, you can see pericardium to the screen right, SVC here. And we saw that this is our phrenic nerve. It was intimately involved here with the tumor. There was no way to free it, so we clipped and divided. Then we turned our attention to the lungs here. It appeared, we initially were going to try and take off a segment, but it was invading both the upper and middle lobe, and it was just not feasible. So we ended up doing a bilobectomy. So here we're just opening up the parenchymal bridge. taking your middle, taking your upper. So this was specimen with, sorry, one last shot here of the lung. So you can see tumors here. This is the lung that's resected, and now we're fully free. And as I said, we took margins all throughout from the chest here. Given that we knew we took the phrenic nerve, we opted to do a diaphragm plication at the time of surgery. We're using a non-absorbable locking stitch here. So we run it both ways. So there's two separate stitches just to lock on themselves. This was the final specimen. It was a mixed germ cell tumor that showed 98% treatment effect. There was some residual mature teratoma and a very small amount of his residual tumor. They did show pleural invasion into both lobes of the lung, and all of the margins were negative for him. And I'm just going to show a picture of his postoperative film here. So he was able to be discharged home on day 3. He had a stable recovery after surgery. He still has a little bit of a elevated hemidiaphragm here, but he did have a bilobectomy. So hard to say if that's all phrenic nerve or also just occupying the space that we took out. We presented him in our tumor board, and he's not getting any subsequent therapy now. So he's just on surveillance. And that's what we have.
Great.
Thank you, Dr. Leslie. Thank you, everyone. We again apologize for technical difficulties.
Not at all. We all have them. Excellent case, excellent case. So many important points were raised. I'll open it up to the floor. Any questions? Maybe Dr. Martinez, do you have any questions?
No, I was very
You know, a few questions come up, and I think they're all kind of open to discussion. You know, these are rare tumors. They're common in young males, as you know, and they respond very well to chemotherapy, such that the primary treatment is always chemo. And then the question becomes if there's still residual tumor after the chemo, and the question also is that tumor all benign teratoma, or is it residual, in this case, embryonal carcinoma? So what was the multidisciplinary discussion on whether you should proceed to such an expectedly big operation in this man?
You're absolutely right, Dr. Abbas. The issue was, it was very large, more than like 15 centimeters initial tumor, and he had relatively good response. And on a PET scan, the tumor was non-FDG avid after the induction chemo with good response, shrinking it by about 4 times. Residual size is about 7-8 centimeters. It was not rebiopsied, but according to guidelines, any residual if there is a residual mass, if it doesn't melt away completely, it has to be resected. So that's why we went with the resection. The mass, as Haley showed, was very large, intimately adherent to pericardium, SVC, with involvement of the phrenic nerve. There was diaphragm elevation beforehand and lobectomy. And the final specimen showed that there was still viable tumor. Majority was necrotic mass, but there was still viable tumor. It was about 2.5% of viable mature teratoma and 0.1% of viable embryonal carcinoma. So there was a residual viable tumor in there. And that's why resection is performed. I think with this minuscule amount of tumor, you would not be able to identify it on subsequent rebiopsy. Only the study of the whole specimen would allow you to find that 0.1% of residual carcinoma. That's why in the guidelines they recommended to have any residual tumor, any residual masses to be resected. That's why we committed to this procedure.
I think in hindsight, it was absolutely indicated. There was still any degree of residual carcinoma will just recur because there was no other indicated plan for therapy, right? If, for example, you had said this is unresectable, we will not resect it, what would have the plan been for this patient? Would it have been just follow-up or would they give more treatment?
If it was truly unresectable, I think, again, I'm not a medical oncologist, probably my hunch would be to give him additional chemotherapy and maybe observe, closely monitor patient with PET scan and see if there are new areas of FDG uptake will show up, because again, on his imaging, there was no active area of uptake. However, if during the surveillance new area would pop up, he probably would get additional treatment. But I think if we were fully ready to full resection, if that was not resectable robotically, we positioned him in a semi kind of prone position robotically. It was difficult sort of exposure, but that was intentionally done in case like emergent conversion, SVC injury, or any other problems. We were ready to go and pump and open emergently, and we were ready to go and resect with homograft available in case of something war of vascular nature or vascular catastrophe to happen. So we probably would commit to resection no matter what. If that was truly unresectable, then it probably would be longer course and tighter surveillance on chemotherapy. I'm guessing fortunately will not for the patient in that situation.
I think what we're hearing is in Dr. Petrov's book, everything is resectable. That question doesn't even come up. I think in my experience, whenever I've done these, actually, this may be one of the few times that there was residual carcinoma. A lot of the time, it's the mature teratoma, which would not kind of metastasize, but the concern becomes that even if you got a PET scan on this patient, it lights up. And even the mature teratomatous tissue lights up. And so it's very difficult for them, especially in a very large tumor like this, to feel confident that they got it all. And so it's kind of a combination of it's a potentially curable tumor. It does go with the guideline. I will, though, say for the rest of us average surgeons, there is an important question to the surgeon of is it resectable or not, or is it reasonably resectable or not? I think that becomes an important question to ask. And usually they'll follow them. If the surgeon declines resection, they will follow them for a few years and then make the decision if they should proceed to a big operation like this one. Does has anyone else had experience with these tumors? I guess another question.
Well, I know, Dr. Abbas, when I was your junior partner, you've done several of those very difficult cases, and that's where I learned how to handle them.
That's not true, but thank you. Roman, and maybe to Dr. Leasley, you did a bilobectomy. A very large portion of the right lung was removed. And you did have to resect the phrenic nerve. But, you know, I hope when I do a bilobectomy, I hope that I don't have a space. I want that lung, that diaphragm to elevate. In fact, some people will actually crush that phrenic nerve intentionally after a bilobectomy in order to make sure they don't have a space problem, especially in this guy. He might ooze from that large raw surface, you might get a hematoma, and you want that remaining lung to fill that space as much as possible to compress that area. I'll tell you, I might not have plicated the diaphragm and dropped it down, because then I would have been worried about that space. I want that diaphragm to rise. In fact, I might have intentionally, if the phrenic nerve wasn't involved, I might have crushed it or injected it at least to get through that. So why did you want to plicate that diaphragm?
It's a good question, and we debated it. You're absolutely right. I think
Dr.
I'm also, sorry.
I agree with I mean, I think you bring up a really great point, and it is something that we talked about because that phrenic nerve had been out prior to surgery, and while he did have shortness of breath, we attributed it more to his tumor compression. So it is something that we kind of debated. I don't think we even, I wouldn't call that even a full plication. So I guess it's a good point. I don't have much else to say to that. I think it's a good point. Yeah.
I think I would add that, you know, according to pneumonectomy data, those patients after pneumonectomy who had phrenic nerve resection / injury had worse functional outcome afterwards. We definitely thought about it, but again, young patient, 27, very functional. We thought the mediastinal would accommodate it, and it's not a pneumonectomy. We still have right low. So that's replicated, at least to give him some better functional status. Obviously, cannot bring up any trials comparing the outcomes.
Right.
Good point. It's a great case. Are you presenting it elsewhere, Dr. Leasley?
We submitted it to ECTSS.
Nodal dissection? Do you do a mediastinal nodal dissection in these cases?
We didn't do any further. We did a basic where we took the lung, we took all the nodes with that. We did take the 2 and 4. That was what we took.
There was one metastatic level 4 lymph node, which was actually we, for the interest of time, cut out of the video. That node was metastatic, however, was completely necrotic tumor within the node. Yes, we did sort of what we could, pulmonary metastasectomy. Lymphadenectomy, sorry.
That's a good point. Thank you. Did you have to open the pericardium?
No. No, actually it peeled off the pericardium fine. It was more difficult around the SVC, but the pericardium peeled off.
Would you have resected the SVC?
If we had to.
Well, how would you replace it?
Well, it depended on how much we needed to resect. If it was possible to patch it, then we could have potentially done autologous vein. Otherwise, we discussed doing a graft, but obviously the patency rates on that aren't as satisfactory.
I've used,
We were not planning to do SVC resection on the robot, just to be clear. We were prepared to open.
we've done the venoplasty, maybe done it together, I forget, and we used bovine pericardium, but just as a patch.
Yeah.
It's hard to get autologous vein during the case. No, outstanding case. Thank you for sharing.
Thank you.
You know, we have some of your friends here, Haley,
I saw that.
Cynthia Stu, and Alice, and Liz Warden. Does anyone else have questions? Cynthia? Maybe, I think we have issues with the microphone also on our computers, so we'll share them, but we look forward to seeing you soon. Thank you, everyone.
Thank you.
Thank you. Thank you for the
Gracias.
presentation.
Gracias.
Thank you everyone for attending. And sorry again.
Oh, my pleasure. Thank you. Bye-bye.
Bye-bye. Thanks.